So just to give you a little bit of background, I'm slightly unusual in that I'm an interventionist, but I'm also an MRI doctor. And I guess because of that, I've sort of influenced many of my interventional colleagues to the dark side of MRI rather than other imaging modalities. So I'm going to give you a sort of talk that really just shows how we use CMR on a daily basis to facilitate our interventional practice in the UK. I'm going to just cover 3 clinical scenarios that we all deal with. So stable chest pain and its investigation, and then scenarios around whether to revascularize hibernating myocardium, so detection of scar, and then finally acute coronary syndromes, and this is probably where the most challenging aspects come. So patients with NSTEMI are quite a heterogeneous group, and the diagnosis behind NSTEMI isn't always related to the epicardial coronary arteries, so I'm going to cover some areas in that clinical scenario. So let's look at stable chest pain first of all. I don't need to remind you probably or even convince you that ischemia is still important despite what some people say from recent clinical trials. We've got decades of observational data here from all the different imaging modalities showing us the importance of myocardial ischemia, but also that revascularizing for ischemia lowers mortality. And also, if you're not convinced by the data, the guidelines that were most recently published from the ESC in 2018 on revascularization show you clearly that all of the class 1 indications for revascularization, all of them have a subtext of saying you need to have proven evidence of ischemia, whether it's non-invasively determined or invasively determined by FFR. So there isn't a clinical scenario where we should be proceeding with revascularization without demonstrating ischemia. And I'm going to show you just one of the landmark trials, first of all, in CMR. And this was quite controversial when it came out. This was a randomized trial that we conducted in our center in Leeds, whereby of all of the 750 patients who went into the study, all of them had CMR and SPECT. It was just randomized to the order of those. And then irrespective of the result, they all had invasive coronary angiography. So even if the 2 tests non-invasively were normal, we still went and did the angiogram, because this is the only study that has actually truly demonstrated the false negative rate of diagnostic imaging. And false negative is really important. And it's that drives the sensitivity. And so what we see in the imaging literature generally is a sort of inflated view of what sensitivity really is, because patients who with negative imaging results very rarely get into the cath lab in clinical trials. And what you see from the data here, if you look at the panel on the left-hand side first of all, it doesn't matter whether you use a visual angiographic stenosis severity cutoff of 50 or 70%, if you look at single or multi-vessel disease. CMR is in the blue curve, nuclear perfusion imaging is in the red curve, and you can see that the area under the curve for CMR, i.e. its diagnostic accuracy, someone's advanced the slides for me, i.e. its diagnostic accuracy is much greater. And also if you look at it broken down by men or women with single vessel disease, someone's playing with my slide set, unless there's some interference on the Wi-Fi. If you break it down by men and women, so the panel at the bottom right, you can see again CMR outperforms nuclear perfusion imaging. And why is that? I mean, we can look at the relationship between non-invasive imaging and invasive FFR, and you can see that those techniques with the highest spatial resolution, so CMR and PET, are the ones that are more concordant with invasive FFR measurements. And so it's really important to understand the concept of spatial resolution. We've got spatial resolution in CMR of around about 1.5 to 2 millimeters for ischemia imaging, compared to 8 to 10 millimeters for nuclear perfusion imaging, so MPS SPECT. So it's a big magnitude of increase, and that means that we can start to see things of much smaller significance like subendocardial ischemia, subendocardial infarction. Another clinical trial that we conducted was to look at using non-invasive imaging compared to what at the time was the UK NICE guidelines. So the NICE guidelines suggested that if you were low risk, then perhaps a CT coronary angiogram as a rule-out test was useful. If you were intermediate risk, seen here in the orange panel, then functional imaging, and if you were higher risk, then direct to coronary angiography. We did a trial that said, well, let's just take non-invasive imaging and say CMR is the first-line test in every single scenario, or nuclear perfusion imaging is the first-line test in every single scenario. And what we showed was that the rates of unnecessary angiography, i.e. when you don't have obstructive coronary disease, were much lower if you did functional imaging compared to following the NICE guidelines. So lots of people were following the NICE guidelines, even in this higher risk group, high pretest probability, were having angiography with no obstructive disease, so unnecessary angiography. And even though we were doing a lot less coronary angiograms, the MACE rates at 12 months and 3 years were exactly the same. So there was no penalty, no safety penalty by doing less coronary angiography. Here's another trial that we were involved with. This was an international multi-center trial of just under 1,000 patients. And this was looking at, again, patients with stable coronary disease, randomizing them to a strategy of either coronary angiography with FFR-guided revascularization or having CMR first and only going on and revascularizing if the CMR was abnormal and only revascularizing those territories where the ischemia was demonstrated on the CMR. And what you can see here, first of all, in the MACE curves, that there was absolutely no difference between those two strategies. So at 12 months follow-up, management by CMR was non-inferior to invasive coronary angiography supported by FFR. Both of the strategies were very safe, and we know that in stable coronary disease anyway, that it's a relatively low-risk group. But importantly, much less coronary angiograms were being performed and much less revascularizations were being performed, but no MACE penalty at all. So what about looking at the scenario of hibernation? We've known for a couple of decades now that if you do CMR, you get an almost post-mortem-like, almost histological-like depiction of where the scar is in the myocardium. So this is a histological TTC stain of a dog myocardium with an induced infarct, and you can see the MRI is almost identical to the scar on the TTC stain. And as I've alluded to before, CMR is really good at picking out the infarct. So you can see the white area of scar on the CMR. It also gets picked up in the nuclear perfusion imaging when it's a big scar, like the histology. But when it's a small scar, when it's a subendocardial scar, nuclear perfusion imaging misses it completely. So this is all about the spatial resolution, as I was talking about before. Why is scar important? Well, we know that if the more scar there is, the less likely the myocardium is to recover after revascularization. So assessing the transmurality of the scar has been shown in multiple observational studies to identify those patients who are going to get functional improvement with revascularization. And here's just a case example. This is an 80-year-old female admitted with heart failure. You can see the ventricle is pretty shocking on the cine images, long axis view here, the anterior wall, inferior wall, not very dynamic. Same on the short axis view. And if you look at the myocardium, it's all nice and black. So there's a little bit of white subendocardially, but generally black is viable, white is dead. You can see she's got lots and lots of viable myocardium. And lo and behold, after revascularization, their ejection fraction improved back to normal, 68%, and you can see the wall motion and the chamber cavity size as well has significantly improved. So a really nice example of extensive hibernating myocardium that was treated by revascularization. If she hadn't have had an MR, it's quite possible that she'd have just been treated with medical therapy for heart failure, but look at the transformation in the ventricle that has been produced by revasc. So what about other scenarios? Chronic total occlusions. Here's a nice case, 51-year-old female, some ST depression on the ECG, and she's got a CTO in the RCA. You can see very nicely that she's got good wall motion, no wall motion abnormality, but she has got a little bit of inferior wall ischemia there, a tiny, tiny little bit of subendocardial scar. But essentially, she's got ischemia outside of the infarct zone, she's got viable myocardium, she had PCI to her RCA. Here's another scenario, similar, CTO of the LAD. This time we can see there is evidence of hypoperfusion in the LAD territory, in the septum and the anterior wall, but it pretty much matches exactly where the scar is on the late gadolinium enhancement images. You can see extensive scar all the way down the anterior wall and around the apex into the apical inferior wall. So she's got no inducible ischemia, no viable myocardium, and the recommendation for her was guidelines-directed medical therapy. So let's just turn now to the last of the scenarios that I just wanted to try and cover. So we're going to look at acute coronary syndromes. We already use CMR extensively in stable coronary disease, but this is a real growth area, I think, in the UK, because NSTEMI, as you know, is quite a heterogeneous condition. We also know that patients who come in with unobstructed coronary arteries represent about 7 to 15% of ACS cases from whichever series you choose to look at. And this creates a bit of a diagnostic dilemma, because you see the sort of coronary arteries are looking normal, you've got a very raised troponin, and you need to know where's the myocardial injury coming from. And it's not a benign, just because the coronary arteries aren't obstructed. I know we get quite focused on the coronary arteries, but when they're normal, this isn't a benign condition when they've come in, and it's still associated with nearly 5% mortality at 12 months. So CMR in this situation is really helpful, because it can actually give you the working diagnosis. And why is that? It's a relatively simple test, but it's multi-parametric. And what that means is not only can we look at the function, we can look at the scar, we can look for ischemia, we can look at the coronary origins to make sure they're not aberrant, but we can also look for myocardial edema, so inflammation in the myocardium because of ischemia, where there may have been spontaneous reperfusion, so that there isn't actually any infarction, but there is evidence of an ischemic insult. So it gives us lots and lots of information in a single test, and we can do this sort of imaging in 20, 30 minutes, something like that. So we do a lot of acute patients because it is really quick and simple to do. And it's the gadolinium enhancement, it's the real sort of deal breaker for us, because this is what has sort of quite pathognomonic sort of patterns when we look at acute coronary syndrome patients. So the distribution of the contrast is really quite specific. So we see, for example, in NSTEMI, you've got typically subendocardial infarction compared to transmural infarction. In DCM, we see mid-wall hyperenhancement. In myocarditis, it tends to be subepicardial with endocardial sparing. Amyloid and hypertrophic cardiomyopathy also have other characteristic distributions. So it really does separate out these different disease groups, where they all tend to present the same as an NSTEMI, often with chest pain, funny-looking ECG, elevation in troponin, but it's not always clear what's going on at the time of angiography. And just to highlight the sort of growing utility of CMR, here are a couple of ESC guidelines looking at STEMI and NSTEMI populations, and recognizing that this MINOCA group, the MI with non-obstructed coronary arteries, really does need further diagnostic interrogation, because the underlying diagnosis is quite diverse. And actually they recommend doing the CMR within 2 weeks if possible. I know that's quite challenging. But the earlier you do the test, the more likely you are to find the abnormalities before there's either been sort of healing and resolution. So it's good to try and do the test as early as possible. Now here's a really interesting study. I think it was done in the US, and this was 114 patients who presented with their first MI, their first NSTEMI. And what these investigators did, which is quite thought-provoking, really. They did CMR on all of them, but didn't tell anybody the results. And then they let them just go to the cath lab as normal. They let the interventionist do what we need to do, and etc. And then they looked at them in a blinded, independent fashion and said, well, what was the real diagnosis? What did the interventionist do? What were they thinking? What did they find? And one of the things that's really interesting is that in those where the infarct-related artery was identified at cath, there were actually still quite a lot of them that had a completely different working diagnosis when you looked at the CMR scan, like myocarditis or Takotsubo cardiomyopathy, amyloid. And in cases where the cath lab didn't show which was the infarct-related artery, again, it was able to be identified by where the edema and where the scar was on the late gadolinium enhancement images. So really quite revealing the discordance between those two approaches to work out, I guess, what the underlying etiology of the troponin release was. But also more interestingly, perhaps, is that out of all those patients who had PCI, 27% of them, so nearly a quarter of them, were actually revascularizing a stable coronary lesion in a non-culprit artery territory, which is, again, I think quite thought-provoking. So I'm just going to finish off with a couple of quick scenarios. This is where we don't always, we think the culprit artery is not what it actually turns out to be. So this was a 36-year-old presented with chest pain, troponin elevation, didn't have much on the echo, but you can see on the angiogram here, he's got a really nice tight lesion in the distal RCA PD territory, and that was stented as the sort of primary PCI culprit lesion. They actually went on and had a CMR then as an outpatient. Troponin was very elevated. But what you can see on the CMR is really quite interesting. All of the scar is up here on the anterior wall, anterolateral wall, in the anterolateral segments. So nothing in the inferior wall at all related to where that acute event was thought to be and where the stent was placed. And actually, when you look at the angiogram retrospectively and go back and look at it, you can see that actually what was missed at the time was a little stump of the first diagonal, and actually the first diagonal was the occlusion and the STEMI, and not that sort of very tight-looking lesion in the RCA. So these are sort of scenarios that we do see, even in big interventional centers, and it's similar to the scenario whereby you've got spontaneous reperfusion and you sometimes look at the angiogram and it looks completely normal, but you can't see where the ruptured plaque is because, as I say, it's spontaneously reperfused. So the lesson, just to quickly mention about CMR, these are 4 big randomized controlled trials that have been done for lots of different strategies to try and reduce the damage done at the time of primary of ST elevation MI. So trials that have looked at LV support, adjunctive therapy down the coronary arteries, vasodilators, remote ischemic preconditioning, and even adjunctive lytic therapies down the coronary artery after the stent has been placed. And all of these, what they have in common is that they've used CMR to assess the primary endpoint of infarct size. And I think we see this increasingly in interventional trials now, where CMR is built into the protocol either as a key secondary endpoint measure or quite often now as the primary endpoint measurement. So it's having a real role and a real impact in what we do as interventional cardiologists. So just to summarize, really, the take-home messages, I think CMR is a fantastic test in stable coronary disease. I would say it's the best test because obviously I'm a bit biased, but it's really good for acting as a gatekeeper to the cath lab, but also guiding our revascularization decisions. But it's increasingly recognized in these acute coronary syndrome scenarios where it's got more utility. So looking at things like late presentation MI, whether you should revascularize, reopen an occluded artery that's presented late, risk stratification with infarct size, microvascular obstruction, post-MI complications like LV thrombus. We pick up lots of LV thrombus now that's been missed on echo because it can be quite difficult to see the apex. And so because we do CMR in lots of clinical trials now, we're seeing lots more LV thrombus than previously. I've talked to you about how it can be really useful in NSTEMI to identify the culprit vessel, and it can also be very useful in those with multi-vessel disease to decide strategies for staged revascularization. And I think the last thing where there's a lot of interest now and a lot of activity is in those patients with acute coronary syndromes and MINOCA to try and actually understand what the diagnosis is. And I would say that almost every day in our unit we're doing a CMR for somebody who's come with an NSTEMI and turned out to have MINOCA to try and work out, is it a cardiomyopathy, is it a missed infarct, or whatever the diagnosis is. So lots and lots of ways in which CMR is really useful.